Stuck inside my mind in this quarantine pause. The light at the end of the tunnel isn't in sight. Where do I go to find someone to talk to about all of my flaws? You can never be, validate me, tell me the light. I searched mental health and I found a therapist online. Said I'm anxious and depressed and my coping skills are not fine. We weren't a fit and it felt like a waste of time. I heard an interview and I felt an instant connection. I learned CBT, BBT, and mindfulness skills and each and every session. I'm pulling through, ready to ask the next question. The next question. The next question. The next question. The next question.
Hello and welcome to NextQuest podcast, where I ask your potential therapist questions so you don't have to. I am your host, Noah S. Garcia, licensed professional counselor supervisor. Today, I welcome to the show Lindsay Tubbs, licensed professional counselor, who will be discussing her specialty, utilization management, health insurance, and advocacy. Welcome to the show, Lindsay.
Thanks.
Good to have you. I really enjoy this topic. As you know, insurance is a mutual interest.
Yeah. How to sell your soul.
101.
101, yeah.
So tell us, what are your credentials and experience?
Well, I have a LPC here in Texas, licensed professional counselor. My master's is in counseling from Sam Houston, Beat 'em Up Cats. Prior to grad school, I worked at Child Protective Services, which is kind of where I decided I wanted to be a counselor. After graduation, I did substance abuse work at a local residential treatment center for adolescents and IOP with adults and adolescents, and then I switched into community mental health. And from there, I went to the insurance game.
So is being a therapist your first career? If not, what was?
No, like I said, I worked at Child Protective Services and loved that job. Loved working with the families and the kiddos that I got to interact with. But in doing that, I kind of learned the difference in being a social worker, being a therapist, and sort of decided on the place that I would fit best. And from there, I decided to go to graduate school and get my master's in counseling because I wanted to work. I started out wanting to work with families in the foster care system and working with foster care parents. Well, not foster care parents, but foster parents, because that was a need that I saw wasn't being addressed. There wasn't a lot of family therapy for foster parents and the kiddos in their home, and kind of helping kiddos adjust to that new environment and this new life. And that's where I did a lot of my practicum work when it was getting close to graduation. And then when I graduated, I realized that I was going to have to create that job if that's the one I wanted, because there wasn't a place for me to do that.
Mm-hmm.
And that's when I got into community health care, community mental health care, and started working with adolescents in the juvenile justice system and those mental health issues, and then later adults who had just been released from prison and also had acute psychiatric issues and co-occurring substance use issues. So
that's quite the population.
Yes.
It's a very needed service to that population. There's not a whole lot of people out there, a whole lot of resources out there.
No, and it's not easy. It's hard.
Yeah. So what brought you to utilization management?
Well, I was working in community mental health, and I had a child, and it became very clear to me that at the end of the day, I had no energy left for myself and to give my new baby. I had spent all of my energy during the day with my clients who were really high need, really high crisis. And I had a friend tell me about this job that they loved, and it really offered them opportunity to leave work at work and come home and spend time with their family. It didn't hurt that the money was way better, and so I took that opportunity and ran with it.
I don't blame you. So, just to let our listeners know, what is utilization management?
So utilization management is what insurance companies call authorization reviews. A customer, we call customers, you guys have them as patients or clients. They come into a service for medical care or behavioral health care. I'm on the behavioral health side, obviously, and they come in for a service. Maybe it's inpatient psychiatric care, maybe it's PHP, maybe it's IOP, or outpatient therapy, and someone has to submit paperwork to the insurance company to get paid for that service. And utilization management is the person you talk to who determines if that level of care is most appropriate and reviews with the provider on a fairly regular basis to ensure that that level of care is A, what's appropriate, and B, necessary, has continued necessity.
And utilization managers are all licensed professionals, correct?
As far as I know, they're usually, they could be LCSWs, they could be LPCs, licensed marriage and family therapists. Different states call them different things, but every utilization manager that I've worked with on the insurance side is a licensed clinician.
Nurses, too.
Yeah, on the medical side.
I've had behavioral health reviews with nurses.
I at least the two health plans that I've been at, the nurses were on the medical side.
Mm-hmm.
I'm not saying it's not possible. I've just not, at least that I know about.
Yeah, she was awful.
Well, an RN, a psychiatric nurse probably wouldn't be so bad. Might be really useful, but.
Mm-hmm. What do you enjoy about utilization management?
Well, not only do I get to talk to people all over the country and kind of see the trends of behavioral health throughout the United States, not just specific to Texas. I get to be included in treatment planning at various levels of care. I also, just on a personal note, I get to be done with work. When work is over at 5 p.m., I get to turn off my computer and go live my life. The stress reduction is amazing and really worth it.
Yeah, I can see that. So tell us a little bit about yourself, like hobbies, interests, TV shows, music, etc.
Well, I am a single mother. I have a 4-year-old, so he's probably my biggest interest. When he's not with me or when I have any free time, I like to sleep and and actively do nothing. That's a big one. I try and do nothing as much as possible. If I have to do something, I like to read recipes. I like to cook. I'm really interested in skincare. I like to, it sounds really silly, but I like to go look at new products and try them out, make my own sometimes.
Oh, cool.
I watch any television show that's going to be so unrealistic that it both entertains and breaks up the monotony of my life. But that started originally with so unrealistic that it was nothing compared to the kind of crisis work that I was doing in my real life, so I could sort of blank out and be unfazed by it. But
what's an example of a show like that?
Like Law and Order SVU.
Okay.
Which was a big one, especially when I worked at CPS, because I could watch it and be like, that's not really how that works.
I know, and it's so formulaic, that show. Like,
I love it. I love it. And Quantico, just finished binging Quantico. There were only 3 seasons, but still a great show. Really makes me think how many government conspiracies there are.
Oh, I know. Don't even get me started.
But I also, when I was younger, I really liked to watch the Bad Girls Club. So sometimes I will still kind of relive the old days and watch old episodes.
That's funny.
Yeah, big fan of RuPaul's Drag Race.
Very good show. They just had a I think the first trans man on the show, didn't they?
They do, yeah. I mean, it's still in its season. I'm a couple episodes behind, so I don't know kind of who's in the lead or what's going on. But the last episode I watched, he was still there, which is a really interesting dynamic to have a trans man as a drag queen. Probably not as, I'm sure that happens more frequently.
Oh, very frequently.
But it's really cool. I just love that show.
I think it's about
I
damn
want to
time.
be a drag queen one day.
There are cis women who
Mm-hmm.
are drag queens. Like, it's a thing. You should look into it.
I don't know that my face would handle all that makeup, but it just looks like so much fun.
I agree. I wouldn't mind doing drag at one point. I think it'd be so much fun.
Yeah.
So we have two different sides of the same coin, right? We have utilization management, and then we have utilization review. For our listeners, how would you define utilization review?
So utilization review is what happens on the facility side. So typically that's what they call their insurance advocates, so to speak, as a utilization reviewer. Oftentimes they're not licensed clinicians. They're just staff in that office, and that's their main focus. They talk primarily to insurance companies all day and try and get authorizations continued. They get clinical from doctors, nurses, therapists, caseworkers, social workers at the facility, whether it's inpatient or outpatient, and they deliver that information to the utilization manager on the insurance side. I guess it's probably really important to specify I work on an inpatient team. So outpatient consists typically of like IOP or just individual therapy, group therapy, family therapy. So the therapist, I think, is submitting paperwork, is the one kind of advocating for continued authorization. Inpatient is your really acute levels of care. So mental health, psychiatric inpatient at a hospital, mental health residential, mental health partial, and then substance use, detox, residential, partial. Some places include IOP as their inpatient stuff, and some don't.
Right. And I think it's important to note that most often what requires authorization or pre-authorization is inpatient, PHP, sometimes IOP, but not all the time.
Correct. Detox,
yeah.
Psychiatric inpatient, residential. PHP they really would like for you to get a pre-auth first, but inpatient, detox, those are kind of considered acute care, and they can admit and then get authorization.
Right.
Same as an emergency room or inpatient things, like psychiatric inpatient, detox, those things are all billed inclusively in the, which is sometimes really tricky for reviewers and facilities. They want to know if they need to get separate pre-authorization for ECT therapy or for a psychological assessment or something, but it's all billed inclusively with that inpatient authorization. So there aren't a lot of separate codes.
Yeah, and
which is nice for me.
Yeah.
To deal with it.
Do you get a lot of people doing PHP with boarding?
Yeah, and most private insurances, that becomes a cost sharing thing. So the insurance company typically does not cover boarding. They'll pay for the PHP program, and then the customer has to figure out boarding on their own. I think most operate that way. And typically that's with substance use PHPs. You don't see that a lot with mental health PHPs because they're typically tied to the hospital or standalone psychiatric facility. But it happens a lot. And it happens a lot with people that are at a residential facility. They step down within the facility PHP because they're no longer meeting that criteria. And then the customer has to come up with boarding on their own.
And so you use the term meeting criteria. Let's talk about that a little bit. So how do insurance companies determine whether they are going to provide coverage regarding a particular level of care?
So it's different for mental health and substance use. So substance use is the easiest to explain, so I'll start with that. Lots of insurance companies use the ASAM criteria, and I could tell you what ASAM stands for, but it's not in my brain right now. But you can Google it and look it up. Many, and throughout the country, they use ASAM, which is helpful because it is standard. Texas has its own medical necessity criteria identified by state health services that kind of helps a clinician or an insurance company determine what criteria is set out to approve initial authorization and then concurrent authorization, which is the initial authorization when they first get there, you're approved for so many days, and then anything after that is when they're actively engaged in programming, they're actively there, and you're reviewing concurrently to see if they continue to meet criteria. So Texas-based insurance companies, like Medicaid, health plans use Texas Administrative Code, I forget the number, to help them determine if someone initially meets or continues to meet that criteria. It's TAC. Everybody refers to it as TAC.
Mm-hmm.
Private insurance companies have now gone to kind of a standardized ASAM criteria that outlines again what's needed to meet initial criteria and then what's needed for that continued stay review.
What is typically needed to meet initial criteria?
So for substance use, let's go level of care. Which level of care would you like to?
Let's see. Let's do a little of let's do a little smorgasbord of.
So detox. So a detox level of care is different. If they're in a hospital and doing detox, it's a higher level of care, requires a very specific criteria. So for ASAM, in a detox level of care at a hospital, they must be getting 24-hour. Your detox must require 24-hour supervision. It's a medically monitored detox with a doctor 24/7, a nurse 24/7. And are they in like acute distress? Are they really in danger of acute withdrawal, like from alcohol or benzos that could potentially kill them? They're being monitored for seizures and other activity. If they're doing detox at a residential facility that has a detox unit, it's a lower level of care and requires a bit more information that's not so medical in nature. They still require that, are they in danger of acute withdrawal? Are they on a taper? Are they being monitored by nurses all the time, but maybe a doctor's only available as needed?
So that's when somebody would do something like a CWA, right?
Yeah, hospitals do CWA assessments, residential facilities do CWA assessments, and those are actually really important in getting getting authorized for continued stay. Detox is uncomfortable, and that's one of those arguments that I find I have with providers and URs is detox is uncomfortable. It doesn't necessarily mean that they need to be on a detox unit.
Right.
If their taper is ending, people take medications in residential facilities all the time. Detox is uncomfortable for a while. If they're no longer in danger of acute withdrawal and no longer in danger of experiencing seizures or really dangerous withdrawal symptoms, they could be stepped down to a residential level of care. And really start working on programming, because in detox, you're not getting programming.
You can't.
No, you're just
you feel like
in a
crap.
bed,
Yeah.
getting your vitals run all the time.
So basically, what I'm hearing and what I know is that initial criteria is based on symptoms. What symptoms are present?
Yes.
So
Yes.
obviously, if somebody has been using alcohol, drinking a liter of vodka for 10 years every day, they're going to be at a risk of,
Elevated vitals, seizures,
etc.
really intense DTs. And so they would be on a detox unit, whether in a hospital or at a residential facility that offers detox as a service. And they may need a 5 to 7 day detox depending on what taper they're on, but it's going to take them a while to no longer experience symptoms. And really that use history is going to be very important to getting both initial and continued stay approved.
Mm-hmm.
So you really have to determine as a clinician, is your client reliable or not?
Right. And I mean, you got to ask the questions like, how often, how much, since when,
And any co-occurring medical conditions,
right.
Because typically people really deep in using are not managing those medical issues. And so...
like diabetes,
fatty liver disease, cirrhosis, Hep C is really common. High blood pressure in someone that's unmanaged but also has a substance use disorder can be very dangerous. And so Detox offers an opportunity to at least get that started, get those medications restarted.
So let's say, I'm going to throw you out, you're going to love this example. Okay. Somebody is seeking inpatient care. Now, they want to go inpatient because their meds aren't working right, and they want to get a medication change. I'm sure you hear about that often. What happens when somebody presents at a hospital for those concerns?
So if they present to a hospital, that hospital is going to determine if they are in acute risk of hurting themselves or others. A medication review in and of itself is not enough to admit someone to a hospital. The hospital may believe it's enough. It's not going to be enough for the insurance company to approve that stay. And there's a whole peer review process, and doctors have to talk, and it's a thing. On the insurance side, we would get that clinical and say, they're not at risk of hurting themselves or others. There's no history of these behavior. It all depends on the clinical that's presented, right? But if it's really just a medication review, they're likely going to be told either
PHP, if that.
Not even PHP. If they have an outpatient provider that's been providing them medications, they need to go see that person.
Yeah.
Insurance companies understand if they're seeing an outpatient psychiatrist, maybe they've tried and they can't get an appointment for 2 weeks. And so if they feel like, okay, I have a history of these behaviors and I have a history of self-injury and a history of suicide ideation.
Like decomp.
Right. They feel like that decompensation is starting, then PHP may be appropriate because they can immediately get a medication review with a psychiatrist and get some new meds started. But if that risk does not exist, like they just feel like their antidepressant is a little low and they'd like a higher dose, they're likely going to be referred back to their outpatient psychiatrist or assisted in finding a new one who can see them more quickly.
I mean, either that or...
Because IOPs don't manage meds. So.
No, they don't. Some do, but some don't.
Yeah.
I mean, I don't think they're reimbursed for that at that level of
They're
treatment.
not. So if they're an IOP associated with a hospital, they would likely bill as an outpatient psychiatric visit, separate from the intensive outpatient authorization.
Now, one situation that I think would make a difference on whether somebody would be authorized for care or not, depending on, like, say, their medications haven't been working, they are decomping, not a risk of harm to self or others, but they have significant medical issues that could be impacted by a change of meds outpatient.
Right, and hospitals can admit someone on an observation level, a 24-hour observation, so that they can really take a look and see if this person needs continued stay at this structure. The thing about inpatient, what we're really looking at is, do they require that level of observation? Do they require nursing 24 hours a day? Do they require a doctor available 24 hours a day? And that's one thing that I know recently I had a facility say, I asked for a doctor's note. What's the most recent doctor's note? And the doctor had not seen that, our customer, their patient, for 48 hours or more. And I said, I just want to be clear, you guys are a hospital. You're an inpatient psychiatric facility. It is our expectation, based on your contract with our company, that you, your doctor, the attending physician, or on the weekend, the hospitalist, sees this person every 24 hours. And they gave me a lot of, well, our policy states da-da-da-da-da-da. I was like, right, but you have a contract with us that requires, as an in-network provider, that requires this service. So we're not going to review until you give me a doctor's note, or, we do something else. But do they require a visit from a doctor 24 hours a day? Do they require nursing and a mental status exam every 2 hours, a nursing visit, a vitals check every 4 hours? I mean, that's what we're really talking about when we're looking at inpatient care, whether at a psychiatric or even a medical facility. If their symptoms don't require that level of observation, then inpatient psychiatric is not appropriate at all. And with private insurance, the customer still has a portion of that to pay.
Right.
So just because we approve it doesn't mean that it's covered 100%.
Right.
People forget that. I think lots of times facilities forget what that will mean for the patient when they discharge. Yes, you got approval from the insurance company.
Right. But now they have to pay for 10 days of $500 a day.
Yeah, they have a deductible. They have co-insurance that they're required to pay. And so if this wasn't necessary for them, you've now billed them for something that could have been treated, could have been managed at a less expensive and lower level of care.
And potentially causing, compounding issues to that psychological condition. Now there's financial stress.
Yeah, I mean, psychiatric
and they haven't been working.
Aren't theme parks. I mean, they're not fun. It's not a break.
Some people
think it is, but
feel it is.
But not, not everybody would. They go to a psychiatric facility and be like, this is not what I thought it was going to be.
Most people do. That's my experience. Most people don't quite understand what the scene is in an inpatient hospital.
Right. It's,
So that a lot of referrals to a higher level of care, whether that be inpatient, PHP, or IOP, comes from private practitioners and private practice. What mistaken beliefs do you think most practitioners have about higher levels of care?
What do I think outpatient providers have, or?
Yeah, outpatient providers like a therapist in private practice who might refer somebody to inpatient.
I do think that oftentimes there is a misconception about what the length of stay looks like. And so I think outpatient providers at times will refer someone to an emergency room or a psychiatric facility to get assessed. And hospitals are so necessary. They also are going to admit almost anyone who comes in to get assessed. And that's not always appropriate. Going to an emergency room to be assessed because the outpatient therapist is concerned doesn't mean that someone is acute, doesn't mean that someone is going to hurt themselves or hurt someone else. But once they get to the hospital, those assessments look different, and it could be determined that for their own safety, they need to stay there. And that's not actually true. And I'll give an example. So I was talking to a reviewer from another state, not in Texas, and the 17-year-old had relayed to her outpatient provider that she was feeling down, had often thought about suicide, had no history of attempts, FYI, but had often thought, my life would be better. Life for everyone would be better if I weren't here. So the outpatient therapist told the mother she needed to take her to the emergency room to be assessed. And if she didn't, the therapist would call the police to take the kid to the emergency room. So mom is immediately scared. She doesn't want the police involved. Takes her to the emergency room. In this particular state, that 17-year-old is legally allowed to voluntarily admit or discharge on her own. It's not up to the parent. They initially did like an emergency hold, which is sort of like an involuntary admission on this 17-year-old. She later signed herself involuntarily, consistently told the facility staff she wasn't suicidal. She doesn't know why she's here. She was tearful. She was scared, as would I be if I were thrown into a psychiatric facility for talking to my therapist. And she called her mom, wanted to come home. Well, the facility then interpreted that and kind of relayed that information to the insurance company, that she's minimizing, that she's guarded, that she's tearful, she's obviously depressed, needs to still be here. And that even though at 17 she had changed her mind and signed a 72-hour discharge notice, the doctor would not accept it and put her on another emergency hold, which again is the same as an involuntary admission. It just caused a bunch of panic in that family, that I'm not saying this kiddo didn't have some symptoms or some issues that she needed to work through, and she went to her therapist to talk about them, and it spiraled into this very serious incident that has now potentially left her traumatized. They didn't do anything to her medications. They didn't adjust them. So that's one reason that people go to a psychiatric facility when they're acute, is to be immediately placed on some medications to help address those symptoms. She was going to group and participating fine. She just didn't want to be in a hospital.
And it doesn't sound like she needed to be.
No, she absolutely didn't need to be.
So I guess where I get confused is why does the provider have to, why didn't the provider do their own assessment of the like plan, means, and intent? And, you know, like, why do they have to refer to a hospital to do that assessment? Like,
that's a really great question. And I wish that I could talk to that therapist and say, what exactly was your role in this? How did you determine that she needed to go? And I'm not saying this therapist didn't. I think, you know, in talking to the facility and then later, because I have contact with the parents and talking to the parent, what that looked like was this 17-year-old saying, I sometimes have these feelings. They've been happening more frequently. And the therapist said, well, something along the lines of, if you were gonna, how would you? And the kid said, I don't know. There's lots of different ways. I guess the easiest might be XYZ.
I mean, that's asking somebody to like entertain.
Right.
You know.
You've now given them, you've sort of implanted in them a plan.
Yeah.
And now they need to go to a hospital. And it just became way more significant in this kiddo's life than it needed to be.
Mm-hmm. Yeah, I think a lot of therapists, especially therapists who don't have experience working in crisis or community mental health in general, are just fearful when somebody expresses suicidal ideations. And I mean, don't get me wrong, it's a scary thing.
It absolutely should be taken seriously.
Right, but you know, I think there's something to be said about, you know, assessing appropriately for the appropriate level of care.
Absolutely.
And that's not something that I think that we're trained on. Like, we're not taught about the levels of care in our like graduate programs.
Correct. In fact, I didn't even know that this kind of job was a thing in grad school. Certainly, I knew how to do a suicide assessment. I knew what assessments existed. And certainly then later working in community mental health, you're using those types of assessments more frequently. But unless you're doing that kind of work, you're right, as just a private practitioner, if that's the only work you've done as a clinician, or even worked in a substance use facility,
mm-hmm.
You're not really doing suicide assessments. You hear someone say they're talking about or they're thinking about suicide, and the hairs on the back of your neck go up, and you run with it, and that's not necessarily the right thing to do.
Yeah, I mean, I think staying calm in those situations and making sure you have all the information before making a plan of action or judgment is entirely necessary.
Yes.
So what would you say, according to insurance companies, which, is who covers it, so that's
Right.
who gets the say of what it is. What are partial hospitalization programs typically for?
On the insurance side, partial hospitalizations are a really good step-down option when someone has been inpatient, and while maybe is no longer acute, still having some residual SI, maybe there's just no plan or intent, but they're still having ruminating thoughts. You've recently changed some medications that take a little longer to activate and need some additional monitoring because perhaps there are some rule-out diagnoses or things that at that very acute level of care you really had the time or opportunity to assess. But you feel like this person, adult or kiddo, needs continued that same structure. Maybe they have a history of really significant SI, maybe even attempts, but both parents work out of the home. And so leaving them alone, even if they safety planned, isn't the best idea. So PHP offers that same structure, but they get to go home at night. They get to see a psychiatrist, sometimes the same psychiatrist they saw inpatient, and really monitor those medications to make sure they're both efficient and the side effects aren't unmanageable, and try out new medications. They might have more long-term symptoms like PTSD that stems beyond just SI or HI, but something that requires a little more treatment. But at an acute psychiatric facility, it's not meant to treat PTSD. Maybe immediate symptoms that can be dangerous, but it's not meant to provide long-term therapy. But this person needs that structure and support. Someone who recently had some psychosis and is less symptomatic but still having some residual paranoia or delusions, and meds are kicking in but not perfect. Let's step them down to PHP and offer that support. If they can function in a group.
Right.
Because PHP is group. And so they also have to be able to
Participate
and function in a group setting.
Mm-hmm. And what about the difference between PHP and IOP?
So I can tell you, for criteria basis, right, PHP is no less than 9 hours a week and no more than like 24 hours a day. PHP is not supposed to include boarding, which is why there's that cost sharing part of it. IOP is no more than usually, I think, like 12 hours a week. So it's not, if it is happening every day, it's like really limited. And
most of the IOPs I've worked at before were like 3 days a week for 3 hours each day.
Yes. And PHP is usually 8 or 9 a.m. to 4 p.m.
Right.
All day. If they're an adolescent, they also have school programming within that time. So they do like morning hours or school, afternoon hours or group. They're also seeing a psychiatrist where, as we talked about earlier, IOPs don't always offer med management. Both will offer family therapy, but PHP is going to be a little more intensive on that family therapy side. And there's usually a nurse on staff. IOP is a lot less structure. I mean, it's setting you up to be home. And not everybody needs to go from an inpatient hospital to one of these step-down programs. Sometimes they stabilize enough to discharge back to their established outpatient providers.
And so what's the difference in criteria from PHP to IOP?
So the acuity level is different. If someone is presenting at PHP with suicidal ideation with intent and a plan, they're not appropriate for PHP. They need to be admitted, inpatient, and stabilized. If someone is having really significant psychosis, more than just some changes to medications need to be made, they likely need to be referred to an inpatient facility. If they've been off their meds for 3 months and experiencing positive and negative psychotic symptoms, they need to be referred to an inpatient facility. if you're talking about someone with a diagnosis like bipolar, if they're actively in a manic episode, not on medications, they likely need to be referred to an inpatient facility. If they are on medications and in a manic episode, they probably can be treated at a PHP level of care because they've got some support. They just need to have them sort of looked at.
Okay. So it's a matter of symptom acuity, really.
Yes.
Now, talking about the actual reviews that occur between a utilization reviewer and a utilization manager, what sorts of information are used in those insurance reviews? Like what does the facility typically gather to relay to the insurance company?
So I can tell you what I ask for every time, which is what most people ask for, despite the level of care. Most recent doctor's note. If they're inpatient or detox, and by inpatient I mean a mental health psychiatric inpatient, or a detox, that's going to be a doctor's note within the last 24 to 48 hours. Especially if it's a Monday, it's probably going to be Sunday's note. If I want the nursing notes, the most recent nursing notes, how are they functioning in the milieu? Not just what they're telling the doctor, but what does their behavior look like on the floor with their peers and with the nurses they're around all the time. Because what happens oftentimes is patients present differently to doctors than they do to nurses. They will oftentimes tell doctors they're feeling great, but the nurses observe something different. In a PHP review, that's no different. Doctors note within the last week, right? Within the last 5 days, because at a PHP they're seen once a week. What do the therapists say? The people leading groups, how are they, again, presenting in the milieu with their peers, with the group practitioners, with the med techs, whoever? If they're doing family therapy, what's that look like? Who's involved? What's the discharge plan? What's the discharge We can't wait
plan?
until discharge to have a discharge plan.
Discharge planning starts day one.
And lots of people don't do that. They're like, well, we can't discharge plan until we have a family therapy session. At the facility, whether it's PHP, inpatient, detox, residential, whatever, discharge planning starts day one, and you should be taking at least a tentative plan to the family therapy session. This is what we have in mind. What do you guys think? How do you feel about this plan?
Mm-hmm.
I hear that so often. Well, we haven't had a family session yet, so we don't have a discharge plan. Well, that's problematic.
Well, I mean, and I think initial reviews are really, I mean, they should be thorough, but you know, it gathers information like symptoms, who does a person live with,
Yes.
history of trauma.
Lots of collateral and historic information helps at that admission review. For concurrent review, which is what I call it, continued stay review is often what you hear on the facility side or with the practitioner, is very different. I, as a utilization manager, can only consider the information within that review period. So the last 24 to 48 hours, 72 hours, maybe, depending on what they were given at admission, or the last 5 days of PHP. I can only utilize that information to determine if they continue to meet med necessity. You can give me all the historical information you want. I can't use it.
Mm-hmm.
A doctor can, in a peer review, can consider that historical data if they've had 3 previous suicide attempts 5 years ago. But I can only look at immediate symptoms, what their current presentation is. And I think that's often, that is often upsetting for the facility side, because they want, well, this kid, has all this historical information. I get it, but they were already approved based on that information.
Mm-hmm.
I can't use the same clinical twice.
And I think it's important to note that when you do these reviews for continued stay, you're often authorizing maybe 1 to 3 days at a time.
Yeah.
And reviews happen like constantly.
Yeah, I will say on the private insurance side, I get a little more flexibility to use my clinical judgment with regard to length of stay, as opposed to, maybe working on at the Medicaid health plan or something like that. However, Insurance companies are for-profit companies.
Mm-hmm.
Even if a customer has a deductible, they have co-insurance that they have to think about, but the insurance company is not going to spend a bunch of money. Psychiatric stays are expensive for everybody. And if those symptoms can be treated at a lower level of care because they have community support, they have family support, they're no longer dangerous, then the insurance company is going to recommend that lower level of care. The goal is not to institutionalize someone.
Right. And I think that it's our ethical obligation to put somebody in the level of care that's most appropriate. Which I mean,
Yes.
often isn't up to us as a clinician. A lot of times that's, if you are doing an initial assessment in a hospital setting, then you do have the ability to say, oh no, I think this person needs inpatient, PHP, IOP, whatever.
Right.
Even though there is pressure in facilities on clinicians to admit to a program, period,
Mm-hmm.
Even if the criteria isn't there.
Well, and I think it's important to note that oftentimes the person doing the assessing is not the person doing the review and asking for
Right.
time. And so if it is important to that clinician, that doctor, that therapist, that treatment team, that this person, adult or kid, stay or admit to a particular level of care, you can't expect the utilization reviewer to know that. Advocacy is key, and if you feel it deep in your soul that this person needs to be in this level of care because they are in danger, you can't just think it. You got to write it down. You got to justify it in your chart so that the person talking to the insurance company can advocate on your behalf.
Mm-hmm.
Because they're not clinicians, there isn't a clinical judgment factor. They don't just know that you feel that way. And quite frankly, if it's not in the chart, it didn't happen. Because at any time, an insurance company can audit your charts.
Mm-hmm.
And if it's not written down in the chart, you just think they're minimizing, or you think they're malingering, or whatever. You think they have a diagnosis that you're trying to rule out, but you've not documented it. I can't do anything.
And that's
about
why
it.
facilities emphasize like documentation
Mm-hmm.
and having good documentation when you're doing a group on a unit, or if you have a one-on-one with somebody, that documentation is so important in the person's overall length of stay. And I think a lot of clinicians don't realize the importance of their documentation and the role that it plays in somebody's treatment.
Yes, and I do think there is some onus on the facilities to provide
That training.
adequate training.
Absolutely.
Even if it means asking someone from an insurance company to come and train them. We get it. I mean, I know I was a clinician. I have a template, right? We use DAP or START or whatever.
SOAP.
Yeah. But it doesn't matter what your template is. If the content is not there, clinicians, we tend to, as clinicians, typically because we're overworked, especially if you work in something like community mental health, and I'm not saying everybody, there's always exceptions to the rule, but you get in the habit of kind of copying and pasting a template and then changing out the information to meet your current appointment, right? That's not a bad thing. You do what you got to do in the amount of time. You usually have like 10 minutes to document before your next appointment. But that means that sometimes really vital information gets replaced with sort of vague, broad terms and generalizations, because you're thinking about it, just how can I remind myself as a clinician that this is what we talked about and this is what we're working on. But from the insurance side, that vague, broad information is not helpful in approving continued stay or admission. You have to be very specific.
Right.
If you're claiming that they're minimizing, how do you know that? How is their presentation supporting your belief that they're minimizing their symptoms? And if you can't give me that, then I just have to think maybe they're not minimizing. Maybe they really don't feel this way anymore.
And, the utilization reviewer, there's only so much that they can do, speaking from experience, there's only so much that they can do with a note that doesn't have a lot of information in it.
Yeah.
And, like you said, I think that's...
They're messengers.
Yeah, yeah. I mean, well, and creating a rationale for continued stay. And I think that's what we need to look at as practitioners. That's how we need to look at our documentation, is a continued rationale for the reason why that particular level of care is required, and like what supports that. So like what symptoms are there?
Why is this the least restrictive level of care for them?
Yes, that's what I was looking for earlier, least restrictive level of care. That's our ethical duty.
But because URs typically are not clinicians, they don't know. And sometimes they know they're clinicians and they understand how they're documenting things, so they know what keywords mean and they kind of will fill in the blanks. But again, if that chart gets audited and it's not in the chart, that could be problematic for your facility. And, it just can be problematic. And it happens the same. I know I talked to someone just the other day, and they're not a clinician, they're a UR, but they work with clinicians, they work very closely with the doctors. And she just kept saying, well, he thinks da-da-da-da, and he thinks da-da-da. And I finally said, listen, I'm going to approve the time because you made 2 different medication changes over the past couple of days. But on Monday, I need you to give me the doctor's note. I don't want to know what you think he said. I don't want to know what you think is in the note. I don't want an overview. I need specific information from your doctor and your nursing staff about why this kid needs to still be here. Because all I'm hearing is you basing this information on why he admitted, what his history is, and I can't use that.
Yeah. And so through our documentation, that is one way that we are able to advocate with health insurance companies for our clients.
Yes. We're not the enemy. We want people to be safe and healthy and doing well and thriving.
Yeah.
But, we can't make up things. If inpatient is the least restrictive, then that's where they need to be. But I got to have a reason why.
Right. I mean, it's kind of like I always used to compare it to like going to court. Like, as a prosecutor, you have to have a rationale as to why.
Evidence.
Right. You have to have evidence, and that's what you're doing at these reviews. Is the reviewer is presenting evidence to you, and you're determining whether that evidence is substantial enough to provide coverage.
Right. And when I worked at CPS and I went to court and said this is why these kiddos could go home or why they need to stay in foster care, it's not just because I think that's what it is. I just have a feeling in my gut they need to be here. This is why. This is what the parents have done or haven't done. This is why that is not the safest place for them. So,
what about as a client? How can a client advocate for themselves in terms of insurance companies?
That's difficult because the actual client may not be available. They can't really advocate for themselves until after they've discharged, or especially if it's an acute level of care or residential. They can call their insurance company anytime with their therapist. But I think it's really important, especially as a parent, if you have a kiddo that's involved in care or in treatment, you reach out, you find out who the case manager is. If the insurance company will call you and say, you or your child has qualified for case management and coaching services. Does that interest you? Sure. I mean, if it's available, you don't have to pay extra, and it's another person checking on you or your child.
And helping link you to services.
Right. Helping make sure that you have up-to-date information on providers in your area that are in network, services that could be beneficial. Most, at least for private insurance customers, they have employee assistance programs that are linked to the insurance. Find out. Your insurance company should be making that information available to you, but you might have to call to get it. Find out who that is. Find out what those services look like, because that could be between 1 and however many free therapy sessions to you.
Yeah.
And But you got to reach out. You have to make that first call.
And so excuse me, is a client able to call their insurance company and say, hey, I'm going through a lot. Is there any way I could be linked with a case manager?
Absolutely. And lots of insurance companies have crisis counselors. They can say, I'm feeling this way, and they will transfer them to that counselor on the phone, who will assess them and find out if they're in danger, if they need immediate, and then here's the local hospital. Can I call you a ride? How can I help you get there? Or they'll connect them to their EAP, who has those same crisis sort of intervention specialists that can help them figure out the immediate need, if the immediate need is like emergency care, or let me set you up with somebody and help you get an appointment, or help you find someone in your area that is taking new patients, and you can call them and get an appointment over the next few days. There are services available, as is with all mental health. Mental health services exist and are available. It's one, do you know that they exist? And two, do you know how to access them?
Mm-hmm. What about, say, somebody presents at a inpatient facility for assessment, and say they're not admitted, but the person really feels like they need to be admitted. What recourse does that person have?
Well, that would happen on the facility side. They would take that up with the facility. In my experience, it's very rare for a facility to deny admission to someone who feels they need to be admitted.
Yes, I agree.
They may not get paid for it. The insurance company or whoever may deny, but hospitals have ways to cover admissions and stays that were not covered by an insurance company. They don't tell people about it, but they have ways of dealing with it.
Mm-hmm. Yeah, they have charity
Mm-hmm.
available, which they don't tell you about.
Nope.
Okay. Well, what other common misconceptions about insurance do you think exist on both the client and the provider side?
I think for clients, patients, I think that there is this misconception that because they have insurance, they're always covered. I think lots of people think that, not just someone trying to admit to a facility. I think, as we all do, I pay for this insurance, I've got it for my family, I should be covered regardless. This is what I want. I feel like I need this surgery. I feel like I need to go to this place. So I'm going to be covered because I have insurance, and that's not actually how it works. And insurance, even if they do approve it, doesn't mean it's 100% covered. You still have deductibles. You still have co-insurance, right? I think on the facility side, there is this misconception that relationship is combative, and it's not meant to be. There are certain times that hard conversations happen between a facility or an attending physician or a clinician and a utilization manager to really kind of figure out what the discharge plan is, what the treatment goals are, why this person has been in treatment for this amount of time, but very little progress has been made, and in fact maybe decompensating, and what that looks like. Where's the facility's onus on that? What changes could be made to improve this outcome? So yeah, sometimes hard conversations happen, but really it's a collaborative effort. We want our customers to be healthy and happy and thriving and living, and functioning in their life, and to function even after this crisis has happened. And that relationship doesn't have to be combative. We're not actually evil soul-sucking insurance people, though that's the reputation we get, I think, sometimes.
I think so too, unfortunately. But yeah, you're limited by what your company says you can and can't do,
And I'm still a clinician. I don't, there is oftentimes I hear, well, you don't really know. But I do know. I have worked with people way less functioning then this person, the history would suggest that they can function again outside of this level of care. We have to trust, and we have to set them up to continue to function. But let's not underestimate them either.
Right. And kind of one of the other things I wanted to talk about is privacy with insurance companies. Now, as a utilization reviewer, as a private clinician, I always provided the minimum necessary information, meaning giving you the least information possible while still saying, like, here's the rationale for what is needed. And there have been plenty of times where I have withheld, some private information. What do you think clients need to know about privacy and insurance?
Well, the first thing that I think everybody needs to know is HIPAA allows for third-party payers to receive information. Insurance companies are third-party payers. You don't need to give the minimum necessary. If they're asking for it, and if they're telling you they need it to justify continued payment, give it to them. We have the same HIPAA guidelines. We're on protected servers. I mean, everything I work off of is secure. It's not going anywhere. What I do find that lots of people don't understand is that many hospitals, while maybe they operate under a different name or owned by the same company, and they have their own intranet and they can access each other's information. So just because someone admitted to hospital A and then 2 years later they've admitted to hospital C, why does hospital C have all their information? That's got nothing to do with the insurance company. That only has to do with the hospital system sharing information, which you should want them to have so that they know. You don't have to re-explain all of your history to them. They've got it in front of them. Even within the insurance company, if a medical contacts me and says, I see they've got this psychiatric history, I will only give them the minimum necessary for that medical authorization. Because we're not sharing information. I'm keeping it. But hospitals have their own systems that they work off of and will have access to that information. But again, it's to save you time and trouble and, re-experiencing traumatic events or,
What you said is true. Under the notice of privacy practices, information can be passed along for issues related to treatment, payment, and healthcare operations, which payment is, an example of payment would be that my office, for example, would disclose somebody's PHI to their health insurer to obtain reimbursement for their health care, or to determine eligibility or coverage. And, I don't need to get a release of information in order to do that.
And you know what? If a clinician's worried about it, you still can get a release of information.
Doesn't hurt.
But you're not required. Those releases of information are for outpatient providers, family members, case managers with some other system. Don't waste them on your insurance company.
And then, I said minimum necessary because I consider minimum necessary to be an ethical issue, not necessarily like an issue of operation, I guess. So, regardless, because sometimes an insurance company might have information about somebody who say they want to join the military, or get some high level of security clearance. Who's to say that, the military can't obtain records from the health insurance to determine whether they will provide that level of access to an individual?
Yeah, your employer is not accessing your insurance information.
Well, I'm talking about the government. It's different.
Well, governments are employers. I guess it could happen in some conspiracy, but
I'm just saying. It has the potential to happen.
The government has their own way of determining if you're safe for service. But really, if we're really breaking it down and we're talking about someone's safety, isn't it all sort of necessary?
Well, I mean, what if somebody had, say, a history of significant suicidal ideations in the past, but, like, they've been doing well for, like, 10, 15 years, you know?
Yeah.
Would that information still be held against them in some way, shape, or form? I don't know.
I don't know either.
And, the other thing that I'm just not sure of is, like, what happens with all the data that's kept by insurance companies? I wonder, like...
Yeah, I mean, it's on a server somewhere.
How long is it stored on the server? Like, how long is it kept? Like, I'm curious about all those sorts of things.
Yeah, I don't have the answer for that. I can tell you we don't work in paper. There's no paper trail.
It's just something I've always been curious about, especially when it comes to, like, marketplace plans, because that, is government.
Yeah, but it's, all I can say is that they're not just accessing your information. As I said before, the military has lots of other ways to find out your history.
True.
They do their own assessments with highly trained psychological personnel.
So you've worked in a variety of settings. What kind of experience do you have working with particularly vulnerable clients, such as those who are transgender, undocumented, or BIPOC, to name a few examples?
Well, I think in all the work that I've done, I have come across people that would fall into those groups. I mean, anybody who has pretty chronic mental health issues are their own vulnerable population. Particularly working with adolescents who are involved in juvenile probation system and their families. Many of them are vulnerable populations. They're minorities or people of color. Even now at an insurance company, I do so many reviews for psychiatric care on adolescents who are transgender. And I have to be really careful because I sort of slip into an advocacy role, sometimes even out of my role, and correcting facility staff. We're doing this review. I'm going to refer, for PHI purposes, we have to do the legal name that the policy is on, but immediately after that, how are we referring to this person? What name have they chosen? What pronouns are we using? And I will correct them. I'm sure it becomes really annoying to lots of people. But when I worked with adults who were fresh out of prison and had acute psychiatric symptoms and co-occurring substance use, that's their own vulnerable population. 80% of those clients had substance abuse problems.
Wow.
Most of them were part of a minority population. Being fresh out of prison is its own vulnerable population. These people have not functioned within a society for many, many years. I mean, I worked with people who went to prison before cell phones were even a thing.
Yeah, that's...
And they're expected to just know how to live.
Mm-hmm.
Only were sober because they were in prison.
And be able to get a job and obtain housing when you can't obtain housing if you have a felony on your record. For most places. Some places you can, but not many.
Right.
Yeah, we do not set that population up for success at all.
No, and especially being in prison for so long, they've set them up to come back because they know they're going to have a bed, be fed.
Because of the industrial prison complex.
Yes.
And privatized prisons.
Yes.
But that's a whole different podcast.
It's a whole other episode. Don't get me started.
So, was there anything that I didn't ask or we didn't get to talk about utilization management, insurance, and advocacy that you would like to mention? Do you think we got it pretty good? basis there?
I mean, I think we touched on a lot of things. I would say if you are a clinician and you are working with a live utilization manager, someone on the insurance side that you are talking to about continued stay, use them. They are clinicians themselves. They have varied experience working with lots of different populations. Use them. We have eating disorder teams. We have substance abuse teams. We have autism teams specific to dealing with services for very specific populations. We have expertise. We have insight. Use us. As much as you're giving us information and we're getting it, let us plan with you. We're not trying to guide treatment. We're not trying to tell you how to treat anybody. But we have information that could be useful.
Mm-hmm. So, in other words, you're another resource.
Yes, absolutely. We're not the enemy. Sometimes conversations may be hard, but that is the nature of life. Mm-hmm. You have to have hard conversations with people all the time.
Those are the best conversations in my book.
It is, but we are a business. The place you're working for is a business as well.
Mm-hmm. Yep. Okay. Well, switching gears a little bit to you as a therapist.
Uh-oh.
How do you define holding space for someone?
I think holding space is just being present. Giving someone the opportunity to talk or not talk and explore whatever is going on inside them. Whether they hash it out or not, just being present and being available and allowing them that space to, really just feel what they're feeling and think what they're thinking and share it or not.
Mm-hmm. Okay. What is the best advice you've ever received from a supervisor?
Don't work harder than your client. Which is really tough to do.
It is. It is hard sometimes. Especially when you're looking at more vulnerable populations.
Mm-hmm. And, there's that common saying, I'm going to say it wrong, but when you hear hoof sounds, don't always think zebras, think horses, or what's the...
I haven't heard that, but I like
saying? Which basically is don't always jump to some crazy, outrageous... It could be exactly what you think it is.
Mm-hmm.
But I think in terms of mental health, you have to sometimes explore those, look outside the box. And that includes but sometimes it is exactly what it is. So many times I see diagnoses like MDD, really, or is it bereavement?
Mm-hmm.
Is it adjustment disorder?
Mm-hmm.
We really have to pay attention to those DSM criteria and the length of time someone is experiencing symptoms, because things like MDD, bipolar, those things stay. The moment someone is assigned that diagnosis in some kind of facility setting, it stays with them. And it may not be the most appropriate identifier.
Well, I mean, not only it stays with them, but I think that a lot of people tend to, when people get a diagnosis, sometimes people will over-identify
Mm-hmm.
with a diagnosis.
Absolutely.
And when, as clinicians, we need to think about the diagnoses that we're giving people, because that does happen, and if you, trying to think of an example.
Well, I notice lots of times some people who have have certain access to diagnoses.
That's exactly where I was going to go.
Will see those other diagnoses as a crutch and use them in a way that justifies continued problematic behavior.
Well, I mean, also...
Not always, but sometimes.
What bugs me, though, is
very difficult to overcome.
Is when clinicians see somebody once and diagnose somebody with a personality disorder of any sort,
Mm-hmm.
I mean, I think that takes, a personality disorder. What makes a personality disorder is a pattern, right? So, we have to allow enough time for us to see a pattern before we diagnose that, in my opinion. Because that's a big thing to diagnose somebody with.
And conversely, when you have someone who's been participating in some kind of treatment program, whether it's inpatient or outpatient, for an extended period of time, and that clinician is afraid to
Discharge.
diagnose them with
Right.
access to with some sort of access to diagnosis when it's obvious, because your treatment, that diagnosis is going to help guide your treatment. And are you treating them effectively if you're refusing to assign
Right.
a diagnosis after you've spent that time with them and assessed them and know that this might be what it is? Are you doing them the most good?
And I think that's something else to note too, is like if you're gonna diagnose somebody with something, then your documentation and your interventions that you're using better be congruent with that diagnosis. Because like we talked about earlier, we're creating this whole like rationale and this whole like.
And treatment plans are supposed to be individualized. It's just...
Yes. Okay. So, what have you personally learned about yourself and or the world through your work?
Well, through my various jobs, but I guess mostly this one, you get really good at compartmentalizing. I get pretty good at compartmentalizing. I've worried in this position that I've maybe lost my edge a little bit as a clinician, so I'll dabble here and there in the private practice sector just to make sure that I'm keeping my skills honed. But especially in this job, there is so much opportunity to see clinical work in a different way. And I certainly was limiting myself in other positions, because I think having the clinical side, having the practical side is necessary, but there is that other side that you really have to understand what diagnoses look like and really have to understand and be familiar with medical trials and medications and things like that. And so this job certainly has provided me that opportunity to be more well-rounded. So that when I am seeing private clients, I have a wealth of knowledge that someone else may not have.
Yeah, and I know a big reason why you wanted to do this podcast is to let other LPCs and LPC associates know, and across licensures as well, that this type of work is an option to community-based work or agency-based work.
Yeah, I had no idea a job like this even existed when I was in grad school. In grad school, we talked about community mental health, private practice, or you could get your PhD and teach other people how to be a counselor. And I'm sure most of my professors would think I sold out, and that's okay. I'm okay with it. I provide for myself and my family. I get to leave work at work and enjoy my time at home. And community mental health and even private practice, it's easy to get burnt out, and this is a really nice option for people who are reaching that point where they're maybe getting burnt out and it's going to ruin counseling. They're reaching the point where they may not be effective for their clients anymore. You can always stop and go back. You can always go back to community mental health. You can always go back to private practice. I know lots of people who do this job and have a private practice concurrently.
Yeah.
It's just an option that no one knows about.
Yeah.
Unless you know someone in it.
Right.
So now you all know me in it.
So what do you do to take care of yourself?
I sleep. I do nothing. Those hobbies.
Intentionally doing nothing. I like that idea.
Actively, people say, what are you doing? I'm doing nothing. Well, let's go. No, I'm doing nothing. I am using this time to sit on my couch and read a book or watch TV, which sounds like you're doing something, but I'm letting my brain rest.
Yeah. How would you define happiness?
As a mood.
Okay.
That
was a quick answer.
Yeah, that's probably something else really helpful, a supervisor somewhere. I don't even know that it was a counseling supervisor, but that happiness is not a destination. We experience moods, and those moods fluctuate. And if you're always looking for happiness, you're going to be really disappointed with yourself for not achieving certain things. And happiness is not a meter for success. It's a meter for wealth or anything. It's a mood I'm experiencing, sometimes more often than not, maybe less often than not. But it's just a way you feel.
Yeah. Fleeting.
Yeah. It's not required to be successful.
Yeah. And I think a lot of people think like, oh, I have to be happy all the time or else
Even all those medications they talk about don't make you happy all the time.
No. They only take the edge off, I like to say.
They get you to baseline.
Right.
That's kind of how I explain it to a lot of people, that if without meds you're functioning or you're decompensating, you're at a lower level than, where you think you should be, the medications are going to get you to zero, and therapy will get you, hopefully, above zero. Yeah. But medications put you in a position for that therapy and that program work or whatever treatment work you're doing to really have a positive impact.
Okay, cool. What is the most embarrassing moment you have had as a utilization manager?
I have no idea. I don't know that I've had any embarrassing moments as a UM. I mean, I talk on the phone all day. I'm not really interacting with people, so I don't. I have lots of embarrassing moments in other positions that I can share, I guess. But so first I will start off by saying that no one was injured. I'm sure when you hear this story, you're going to gasp and be like, oh my gosh, we should report her. Please don't. It was several years ago and no one was injured. I know for a fact. But when I worked at CPS and I was a caseworker, I had to sadly remove a kiddo from the hospital. This is a newborn baby. I took this newborn baby to her new foster parents, and I get in the house. It's late at night. This had been like a 24-hour day. It was crazy. I get that new baby to this foster home, and the foster parents didn't tell me, watch your step. There's a step right there. I fell with this 3-day-old baby.
Oh my goodness.
In my arms. See, gasp. Let me tell you, that baby was protected like a football. That baby didn't even shake. She didn't cry. I landed on some toy tool desk and I had a sore neck for 3 days, but because I hit it with the side of my head, and it was but that baby didn't even shake. I didn't know I had those protective capacities in me until then, and the foster family was, oh my gosh, are you okay? And I was just like, take the baby. I'll get up on my own. I think she was asleep. She stayed asleep. So before you get all concerned for this child who is now 13, she's fine and functioning and healthy, but it was a bit embarrassing. After the fear wore off, it was then just embarrassing. And then anger. Why didn't you tell me to watch my step? I'm sure I'm not the only person that's tripped.
Rude.
Exactly. Did you want this to happen? Anyway, it was pretty embarrassing.
Yeah, I could see that. That sucks. It's hard. But
it also
total shock absorption.
Hurt. Yeah. Yeah, that baby was fine. She was nestled like a little baby.
Well, another vulnerable question.
Oh.
Are you in therapy, or have you ever been in therapy yourself?
I have been. I'm not currently. I probably should be. But I have been. And I have been as a therapist. And it's much harder. Therapy is harder as a clinician because I'm looking for very specific therapy things. Not like I'm looking for this type of clinician. I'm observing them to see what types of things they're using on me that I know about. And it takes me completely out of the session. It is harder for me to allow myself to be vulnerable in therapy as a therapist. Yeah. Maybe I'm not the only one. I'm sure I'm not.
Kind of like doctors are the worst patients.
Yes, I tend to, when I call to find a therapist, the first thing I relay to them is, I am a counselor. Caution.
Okay. Well, is there anything else that you think would be good for potential clients, therapists, to know about insurance, or you as a utilization manager?
No, not me. Not me as a UM specifically, because I'm just some unknown person, but ask what your EAP benefits are. Most employers provide them. Familiarize yourself with them. There's so many services available that you don't even know you have, and that EAP is an amazing resource. I mean, even in finding childcare.
Oh, really?
Yeah, I mean, it's
good to know.
It's crazy. Just ask them if you have EAP. Get the phone number. Your employer will provide it to you. HR typically is who has that information on hand. Call them and find out what's available to you.
Awesome. Well, thanks so much for being on the show, Lindsay. Love talking about this stuff.
Thanks for having me.
The next question. The next question. The next question. The next question.
Thank you for listening to NextQuest podcast. I learned something new today, and I hope you did too. Next week's episode will feature Greer Culbertson, licensed clinical social worker, who will be discussing her practice and area of specialty, mindfulness. NextQuest podcast is sponsored by Jan Dimmitt Resources. Save yourself the time and stress of credentialing and let the experts at Jan Dimmitt Resources do what they do best. For over 20 years, Jan Dimmitt Resources has provided administrative support and credentialing services to mental health professionals in Texas and beyond. Visit their website at jandimmitt.com. That is JANDIMMITT.com, or call 512-731-5725 for more information on all the ways they can make running your practice easier for you. NextQuest podcasts rely solely on donations to keep this project going. Please consider becoming a patron on my Patreon page at www.patreon, that's patreon.com/NextQuestPodcast, or you can make a one-time donation on my website at www.nextquestcounseling.com/aboutnextquestpodcast. You can also support the podcast by liking our Facebook page. Until next question, this is Noah Garcia signing off.